Thank you so much for coming today. My name is Lindy. I'll be going over a lot of information. Feel free to ask questions. A lot of you might be here for different reasons. Maybe you're on a CPAP and you're looking for alternative solutions. Or maybe you have a child that's struggling with ADHD or bedwetting and you're looking for solutions with that also. By the end of this presentation, my goal is that even though all of these things seem so different, you'll understand that there's a common root cause. So let's go ahead and get started here. We are seeing a silent crisis in America. If you look at the left-hand side of the screen, you'll notice a long list of symptoms. These are symptoms we typically see present in children. Things like ADD, ADHD, bedwetting, difficulty in school, mouth breathing, delayed or stunted growth, low IQ, chronic allergies, crowded and crooked teeth, dark circles under the eyes, swollen tonsils and adenoids, just to name a few. On the right-hand side, you'll see a long list of symptoms and comorbidities that we typically see present in adults. Things like depression, anxiety, obesity, bruxism, that's when we grind our teeth, Alzheimer's, diabetes, dementia, and premature death. What we know is that research has shown that 9 out of 10 in America suffer from one or more of these conditions. So we're going to look at a few images of children. And in these images, there's some things that stand out to me. And I'd like to show you and point those things out to you as well, so you can begin to understand some of the things that we look for in our patients when they come into our practice that leads us to believe that something else might be going on. So if you take a look at this image of the little guy on the far left, his name is Michael. You'll notice right away he has a retrognathic chin. That is a double chin, pushed back chin. And the double chin actually gives him the appearance of being overweight. But what we'll learn as we move forward in the presentation that he's not overweight at all. He's just severely underdeveloped in the lower 2/3 of his face, which gives him that appearance of the double chin. Now this little girl in the center, you'll notice that she has some dark circles under her eyes. When we see that, we know that that's typically what we call venous pooling, and that's also due to the underdevelopment in this region of our face. She also has a really tiny chin, a dimpled chin, and she has red, dry lips, so that could be attributed to mouth breathing. Now, if you look at the little guy on the far right, he has some symmetry issues going on. So you can see it a little bit in his ears, his eyes, they're not aligned. He also has the double chin. So little chin looks like he's underdeveloped in this region too. And he also has really dry, chapped lips. So probably a mouth breather again. Let's look at a few more. So if you see the image on the far left, the little girl has her head tilted to the side. That's what we call a cervical head tilt. When we see patients that are typically posturing with their head to the side or their head moved postured forward, that's typically due to them trying to open up their airway. They're trying to compensate for breathing. So they tilt their head to the side or they push it to the front so that they can breathe better. She also has the dark circles under her eyes and a little tiny chin and a really, really long oval face. And we'll touch on that a little bit as we move forward. The little girl in the center, you can see right away, she's got a little bit of symmetry issues in her ears, really, really tiny chin. So looks like she's severely, underdeveloped in this region. She can't even close her lips over her teeth. Her teeth protrude from her mouth. And she also has something that we call sclera. So when you're looking at a patient straight on and they're looking at you, we shouldn't see the whites under the eyes. That's what we call sclera. And this image of the little girl is looking up a little bit, but she does have that as well. And then this little girl on the far right just really looks tired, but you'll notice again in this image, she has the bright red chapped lips and the splotchy skin. In fact, all of these children tend to look really tired, and that's just, what we see a lot of these days. And I want to touch on the fact that we will look at a lot of, children. We'll talk a lot about that throughout this presentation, just children and a lot of the symptoms and things that we're seeing in them, because what we know is that if we don't get a lot of this stuff corrected in childhood, it tends to stem to adulthood. So a lot of those symptoms that we saw on that first slide, those comorbidities, things that we see present in children, we want to correct a lot of that early on so we don't have other issues when they move into adulthood. So visible symptoms, those are all some of the examples of visible symptoms that we see in our patients when they come in our practice. So just like we see leaves on a tree, that's the outward appearance of a tree, right? But if we follow that tree trunk down, we can't see what's underneath. right? So the visible symptoms that we see in our patients, things that they're also telling us on their questionnaires, things like, yeah, I'm having difficulty in school, or yes, I have, chronic allergies. Yes, my son is a bedwetter. Or maybe as we're doing exams on our patients, we can physically and visibly see that they have the dark circles under the eyes. They have the crowded crooked teeth and the swollen tonsils and adenoids. So what we know in these visible symptoms is that there's an underlying cause. And we're going to talk a lot about this today. And that underlying cause is a compromised airway. And there's a possible root cause, and we're going to talk about all of this as well. Things like narrow dental arches, soft food diet, a weak tongue, processed foods, weak facial muscles, low tongue posture, a tongue thrust, and limited to no breastfeeding. So where in the world did all of this come from? And why do 80% of our children typically need orthodontics today? This is really what we want to see. This is what we call a perfect 5-year-old. So you'll notice right away in this image, there's these beautiful U-shaped arches, but also in between all of these little baby teeth, there's space. There's adequate space there. So we know that when the babies are about to fall out and the permanents are ready to come in, there's going to be room for the permanents to come in because there's space right now to do so. Tongue posture also plays a really critical role, and we're going to talk a little bit about that palate that we're looking there, that beautiful low palate. But this is something we don't see too much of anymore, and that's why we're calling it an endangered species. And why is that? Is it because all of a sudden we have large teeth, or could something else be going on? I love this slide, and this is a really good visual into how we grow and develop in our craniofacial structure. So this is what we call normal craniofacial growth. So you'll notice in this image, the skull is made up of tiny lines. The inward line of the skull is the size of a 2-year-old skull. The outward line of this diagram of this skull is that of a 17-year-old. So you'll notice that most of the growth and development between the ages of 2 to 17 isn't happening here. It's not happening in this region. It's happening here, and it's happening between the ages of 2 and 17. So that's a lot of the reasons why we talk a lot about children in this presentation, is because we want to capture the ability to do something about it early on when these children are growing in their primitive years. And like I said, most of the growth and development between those ages is happening right here. And what we know is that normal craniofacial growth is wide, it's forward, and it's downward. So these are some fun statistics here. By 2 years old, we're about 55% developed in our jaw. By 4 years old, we're about 73% developed in males and 70, round on up, 8% in females. By 12 years old, we're about 89% developed in males and 94% developed in females. Again, those really early years, we're about 94% developed in our jawline by the age of 12 in females. So again, what we know is normal craniofacial growth is wider, forward, and downward. So why are so many children suffering from abnormal growth and development? We're going to dig into that. And in doing so, we're going to look at some research that was done by Dr. Robert Coracini. Dr. Coracini is an anthropologist. He's done over 30 years of research, published several books and articles, but what he's really well known for is his fossil studies, particularly human skulls. So what Dr. Coracini did is he researched skulls from 400 years ago, and he compared them to modern day skulls. And in his research, what he found was really interesting. With the skulls from 400 years ago, what he found is that they had these beautifully U-shaped arches, and they had room for all 32 teeth. Whereas in modern day, we barely have room for 28 teeth, let alone 32. And I'm sure some of you here probably have had some form of extractions. I know I have. I've had my wisdom teeth removed. How many of you have had your wisdom teeth removed? Raise a hand. How many of you had your bicuspids removed? Raise a hand. Yeah, most of us have had some form of extractions, right? But why is that? 400 years ago, there wasn't orthodontists, there wasn't oral surgeons, specialty doctors to make things like that happen. Yet they still had these perfectly formed upper and lower jaws and room for all 32 teeth. It's really interesting, right? So Dr. Coracini wanted to dig into this a little bit. He wanted to see, wow, is this really happening still today? Are there other people that are growing and developing differently? So what he started doing is he started observing isolated rural populations around the world. And in that observation, what he discovered is, yes, they are developing differently, but they're introduced to things differently also. What they're doing differently is they're being breastfed for many, many years. They're also on a hard food diet early on in childhood as well. And as a result of that, they have little to no incidence of crowded or crooked teeth or other degenerative diseases. And they have these perfectly formed upper and lower jaws. So some of his conclusions behind that research were dietary consistency and toughness promote proper bone growth. And when non-resistant processed food became ubiquitous after industrialization, malocclusion or crowded crooked teeth showed a rapid rise. And a soft food diet or processed food increased the underdevelopment of upper and lower jaws and malocclusion or crowded crooked teeth. So Dr. Corricini wanted to take his research just a little bit further, and he wanted to observe these isolated rural populations as they became introduced to Western culture. And he wanted to see what was going to happen when they were introduced to these different changes in their diet and things that they're introducing into their lifestyle. And what he recognized was by the first generation, the rates of malocclusion started to increase dramatically. By the first generation, the rates of malocclusion in these populations increased by 50%. By the second generation, they increased by 70%. And by the third generation, they increased by 85%. Wow, that's a lot, right? And here's a fun fact for you. It takes 27,000 years for a genetic mutation to express itself in 51% of the human population. Yet how did it happen in just one generation, right? So what that told us is most malocclusion is acquired. It's not inherited. I think a lot of us tend to think, well, my mom and dad had braces when they were younger, and I'm probably going to need them too. But what this research shows us is that that's not true. This is something that's acquired, not inherited. It's acquired by things that we're introducing into our lifestyle. And what we know is malocclusion is a disease, and it's caused by Western culture. So let's talk about this, right? What is Western culture? Well, inadequate breastfeeding, absolutely. You know, I'm a mom. I'm a busy mom. I work full time. I have 4 kids, and really every one of those children, I didn't have the luxury of having, you know, the benefit of breastfeeding my babies for 2, 3, 4 years. And in fact, most of us have, you know, limited time with maternity leave, maybe 3 months, give or take. And then what do we do from there? Well, we're not breastfeeding anymore, so we have to feed our babies, and we transition them to a bottle, right? So let's break this down a bit. What we know about breastfeeding is, yes, breast is best for nutrition, but what we don't understand is that breast is best for how we're growing and developing. So when we're breastfeeding our babies, the tongue posture of the baby is very different in that when we're bottle feeding. So when we're breastfeeding a baby, the tongue is actually up and forward in the palate. It's in the roof of the mouth where it should be. And when the babies are breastfeeding, man, they're working really, really hard to get that milk out. If anybody has ever breastfed, and I know that I mentioned I've done that for a few months with my babies, but it's really different in that when you're bottle feeding, and you can see the babies working really, really hard to get that milk. And they're working so hard sometimes that you see little beads of sweat on their forehead. And when they're doing that, they're working these facial muscles really, really differently in that when they're bottle feeding. When we're bottle feeding our babies, if you noticed, the tongue is different. The tongue posture is different. So the tongue is actually low in the mouth, and the nipple sits on top of the tongue. And I think more than not, the babies are not working as hard to get that milk out, and it tends to just flow down the back of the throat a little bit easier than when they're breastfeeding. So we take them from the breast, we take them from the bottle, and then what do? We introduce them to a soft food diet, right? Things like this. And I have had every one of these in my pantry, in fact, so no judgment here. It's really interesting though. And now knowing what I know now, when you look at these packages, it seems kind of elementary to me. You know, why do we want things why do we want to give our babies things that say melt in their mouth good? Why do we want things to melt in their mouth, like these Gerber graduate puffs, the applesauce pouches, the yogurt sauce pouches? Well, we give these things to our children, yes, because of convenience. It's really easy to go to the store and just pick these things off the shelf and call it a day when it comes to feeding our babies. But we really, truly, I know I did give these things to our babies because we're afraid they're going to choke. Right? So we give them all these soft things early on, and then we transition them to what we think are solid foods like macaroni and cheese and spaghetti and chicken nuggets. But again, they're still soft. But 400 years ago, what do you think they were feeding their babies? They weren't feeding them macaroni and cheese. I can assure you that. The babies were eating hard root vegetables. They were eating jerkies and meats, things that were tougher and harder. And in doing so, it was promoting different growth and development in this region. They were using these muscles early on, and they were growing and developing differently as a result. So some research conclusions here by Dr. Robert Corcini's research is most malocclusion is acquired, not inherited. Malocclusion is unique to Western culture, and the presence of malocclusion is the key indicator of an underdeveloped airway. All right, so we talked a little bit about tongue posture. So let's talk about that a little bit more and look at some research that was done by Dr. James Sims Wallace. Dr. Wallace discovered early on that a soft food diet prevents the development of muscle fibers of the tongue, which results in a weaker tongue, and that tongue can't drive the primary dentition out into a spaced relationship with fully developed arches, which will lead to more crowding of the permanent teeth. So here's a good visual to kind of back up that research. And I love this visual because I'm a visual learner, and I learn better that way. But think of your tongue as the scaffolding for your jaws. So like I said, your tongue should be up and forward in the palate, right? Well, what we know is when the tongue is up and forward in the palate, it actually is acting like a natural retainer. It's almost like having a little orthodontist in your mouth, because it's keeping your teeth in place. It's keeping them where they should be. When the tongue isn't able to get up and forward in the palate, maybe it sits down low in the palate because there's not a lot of room, or maybe they have a tongue tie. There's lots of different variables there. But when the tongue can't get up and forward in the palate, we see a lot of the high rates of malocclusion, crowded, crooked teeth as a result of that. So think of it like this. Your house has scaffolding, right? And what happens if the scaffolding in your house crumbles, or it falls, or it shifts? Well, the bricks of the home are going to change. They're going to shift. They're going to move and crumble, really, essentially. So it's the same concept, but behind the function of our tongue. Our tongue is supposed to be up and forward in the palate and really retain the teeth. So this is a good image to kind of explain what I'm talking about, right? On the far left, we see a lot of these Gothic arches, these high vaulted palates, the high rates of crowded, crooked teeth. You can see in that image that the tongue probably isn't getting up and forward in the palate like it should. Whereas the image next to it, that beautiful U-shaped arch, the lower palate, we know the tongue is functioning better there. The tongue is able to get up and forward and really into that natural parking spot. So let's talk a little bit about the maxilla. The maxilla, yeah, it definitely houses our upper teeth, but it does much more than that. And I think a lot of us don't understand that it really takes up this whole region of our face, and it makes up our sinus cavities and our eye orbits. So there was some research done here by Dr. Christian Guillemont, and that research suggested that dental arch expansion improves sleep disorder breathing in patients with upper and lower jaw constriction, and it can be a valid treatment. So what does that mean? So we see a lot of the images on the far left. We saw this image already. You can see how narrow that palate is, right? And then look at it to the next one, in comparison, that's a lot wider, right? There's more space there. So that's what we're talking about when we're talking about expansion. We have that narrow one, and then we're getting that wide, beautiful U-shaped arch lower palate by the expansion. And these are some CT scans underneath these images that give you more visual into what's going on here. But what I think is really fascinating about both of these CT scans is the green line. The green line right there is actually the airway. So we just talked about how expansion improves sleep disorder breathing in patients. Well, when we're wider here, then it's opening up our airway too, so we're able to breathe better, right? And CT scans are something that we do in our practice. We want to see, our patient's airway. So we will take a series of those so we can see yours as well. So what is the functional airway? This is another great image to really dig into, how we breathe, how this area of our face functions. And what you can see just by looking at this is how we grow and develop in this region severely affects how we breathe, our lower airway, our upper airway. So for example, if we have a really high palate, right, where is that going? that's going to be obstructing our nasal breathing, our nasal cavity. So it could really play a huge role in how we're breathing through our nose. If we are really underdeveloped in this region and we have that retrognathic chin, that chin is pushed back, the jaws are really small and not developed the way they should be, well, then where is that going? That's pushed back, and it can obstruct our lower airway, especially the tongue. If the tongue isn't, doesn't have a lot of room in the mouth, well, it's going to go somewhere. And where's it going? Well, we see that fall back when, our patients are struggling to breathe, and lo and behold, we have sleep apnea. So what does your airway look like? Are you breathing through a narrow straw? Are you breathing through a wide garden hose? So as I mentioned, in our practice, we take a series of CT scans because we want to see how you're breathing. We want to see your airway. And these are some examples to that. So on the far left, you'll see a CT scan of a severely constricted lower airway. The red is not what we want to see. So I mentioned a minute ago, are you breathing through a narrow coffee straw or a wide garden hose? And you'll see in this image, that's a tiny airway. That's that narrow coffee straw. The one next to it is a typical mouth breather. The one next to that is a child with Asperger's syndrome. And then we have an adult with sleep apnea. So we're going to watch a quick video. I love this video. It just sums up beautifully what I just went through. We're going to watch it really quickly, and then we'll come back thereafter.
Just a few hundred years ago, the human face was different. It was forward grown. Her wide profile and large dental arches ensured straight teeth and room for her tongue. Most importantly, she had plenty of space behind her upper jaw so she could breathe through her nose with ease. The modern face has changed. From childhood, her dental arches are less developed, crowding her teeth and giving her less space for her tongue, which impacts her airway. Many believe this stems from a number of causes, such as allergies that affect breathing. Another is the poor nutrition and softness of modern diets, causing toddlers to have underdeveloped chewing muscles and smaller dental arches. Because her upper jaw is too far back, she will struggle to breathe normally through her nose. To get more oxygen, she will compensate by opening her mouth to breathe, bringing her lower jaw down and back, creating a downswing of the face. This is how her undergrown upper jaw creates the appearance of buck teeth. She's actually compensating in order to breathe. If not corrected, the problem carries into adulthood. Extractions were documented in the 1600s as a way to treat crowding. Although they are a quick fix, they don't treat the problem of underdeveloped arches and have been implicated in harming the facial profile, making them the subject of much debate even today. Adulthood. In order to breathe, she will slouch her head forward to prop open her airway, creating a lifetime of neck and back pain. This is the infamous forward head posture. Having a healthy airway is crucial to the survival of life, and especially so during sleep. When muscles around the throat relax during sleep, a healthy airway stays open because the tongue is sitting forward and has enough space to be suctioned up against the fully grown palate. With underdeveloped jaws and dental arches, the palate is too small for the fully grown tongue, which is sitting back to begin with. When she sleeps, her tongue does not suction, rather it falls back and cuts off her airway. This is obstructive sleep apnea. Like crooked teeth, it's a modern condition, however, it can reduce life expectancy. Not surprisingly, obstructive sleep apnea is marked by the same traits that describe the headgear effect. Both jaws are grown down and back, creating a clockwise rotation in the lower third of the face. The myth of the overgrown upper jaw that needs to be held back has long since been replaced with science. Science has shown that young children can be buck-toothed naturally, and that the lower jaw catches up over time with a fully developed upper jaw. Essential to this is nutrition, the use of chewing muscles early on in life, and good breathing habits. This means breathing through the nose with the mouth closed and the tongue resting up against the palate. Also, the practice of maxillary expansion has been shown for over a century to correct crooked teeth and improve nasal breathing space. And since 1918, orofacial exercises have been shown to correct mouth breathing habits.
Interesting stuff. All right, so we're going to watch another quick video here. I want to introduce you to baby Eli. So this video was actually recorded by baby Eli's mother. Really kind of tough to watch, I feel. Not sure if any of you have ever seen what it looks like when someone is struggling to breathe, but we're going to watch that today. So what I want you to pay attention to is when Eli's mother does what she does in the video, watch baby Eli's complexion. Watch the changes in him as a result, and then we'll come back and talk about it thereafter.
Okay, this is a picture of Eli holding his breath. Right now he's snoring. We're going to see what happens. This is February 6, 2009. There he goes. See that? He shakes. He's kind of woke himself up. Okay, now let's listen again. Quiet. A few seconds he'll probably hold his breath again. You can hear him snoring. He's breathing through his mouth, not through his nose. And he's not congested now. He doesn't. There he goes, I think. There he goes. Saw that? Now he's gasping for air. The breath he took beforehand, he was actually not getting anything into his lungs. Now again, he's only kind of... He's not really getting anything in right now. Now he's going to take a deep gasp in a few seconds. There he goes. And again, he's going to hold it now. There goes a deep breath again. That was a clear breath. And now again, he's going to start holding it. All of these breaths that he's taking right now, he's not really getting much into his lungs. There he goes. Now every time he shakes like that, he's essentially disrupted his sleep. Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Okay, now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and now he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying to... There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now, watch what happens when I take his jaw and I just bring it forward. If I can. We'll see if I can. And I open his airway. Just bring his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose. his airway. I'm opening his airway, just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. Just by, you hear how quietly he's breathing? You don't hear him anymore. And all I did is gently bring his jaw forward. That's it. Essentially allowing the air to go in through the nose and clearly down into the trachea. Tonsils aren't blocking anymore. I'm going to let go. Let's see what happens. Now he's in a comfortable position. The jaw is still forward a little bit.
All right. So interesting, right? And if you paid attention, what happened when baby Eli's mother pulled his lower jaw forward? Well, he started breathing through his nose, right? His complexion changed. He literally, his head kind of fell to the side as if he was just immediately able to relax. And really, it was a result of being able to breathe better, right? And so looking at these images right here, this gives you a good insight into really what was going on with baby Eli, looking at that really severely, underdeveloped chin. Where is that going, right? There's no space here. You're pushed back. There's no room for the tongue falls back, and there we go. We're struggling to breathe, right? So let's talk a little bit about the importance of breathing through our nose, as we just witnessed with baby Eli, versus mouth breathing. So what we know is when we are breathing through our nose, the air we're breathing in is actually, it's moisture, it's filtered, it's humidified. Our body is actually producing something called nitric oxide also. That is a vasodilator. It helps the blood flow, the oxygen move through the body quicker, more efficiently to our vital organs. That isn't happening when we're breathing through our mouth. In fact, when we're breathing through our mouth, we're breathing in everything from the outside, and then think about it, where's that going, right? It's going to the back of our throat. And as a result of that, we're seeing a lot of the high rates of swollen tonsils and adenoids. So breathing through our nose is extremely important. To back that up a little bit, we're going to look at some research again. This is some research that was done by Dr. Eagle Harvold. Dr. Harvold wanted to see what would happen if you took monkeys who were once nasal breathers and made them mouth breathers. So what he did is he obstructed their nasal breathing by plugging their nostrils with cotton rolls. And I always throw out a disclaimer here. In this research, though it was done on monkeys, the research was done over about a year period of time. And then after that research was over, the monkeys were, everything was fine. Everything went back to normal, and no one was harmed in these studies. So again, what he did was he plugged these monkeys' nostrils with cotton rolls. And as a result of that, what he recognized really quickly is that these monkeys started changing. They started developing differently too. And you can see some before and afters here. So the far left image of the monkey is when the monkey was breathing through the nose, then in comparison, breathing through the mouth next to it. And you can see right away the structural changes in the face, right? So imagine if we are mouth breathing all day, every day, what that does to the face, the structure of the face. And you can see these before and afters here. The changes there. If the mouth is open all day long, we're breathing through the mouth, well, don't you think our face is going to probably see some changes as a result of that? Yeah, absolutely. And also, if our tongue is not up and forward in the palate where it should be, and it's low and down, we're going to see those high rates of malocclusion. And that's exactly what happened in the research here with the monkeys. And you can see the before and after there with the tongue posture and then the teeth alignment as a result of that. So here's what we know. When you have a compromised nasal airway and you breathe through your mouth, it leads to low tongue posture. Yes, we have to breathe through our mouth. That is the fallback if we can't breathe through our nose, but it's not the way we should be breathing. And what we also know is mouth breathing causes the tonsils and adenoids to swell, which further impacts our ability to breathe, right? So let's look at some research here that was also done on, for nasal breathing versus mouth breathing, but it was done on children. This research was done by Dr. Stenlinder Aronson. And her research was on children, and the focus was on the difference between nasal breathing and mouth breathing in children. And her outcome, her clinical observation outcome, is that mouth breathing children do develop differently. And nasal obstruction leads to mouth breathing and low tongue posture, and that leads to a higher rate of malocclusion. So it's really, really important, folks, that we get breathing through our nose. All right, so ADD, ADHD, you might be wondering, wow, how does this remotely relate to ADD? So I mentioned in the beginning that we see a lot of children come in our practice that struggle with ADHD. Well, I mean, think about it. When you have a child that's struggling to breathe, well, no wonder when we get them in a school setting that they're unable to focus. They're tired. So we're going to watch another quick video by Dr. Ben Moralia, and he's going to explain the association.
Now take a child, alter their quality of breathing and sleeping. And the real big issue now is how will they be during the day? So now you take a child who's 5, 6, 7, 8, it doesn't matter. Their issue has begun years ago. So it's not like you had 1 or 2 bad nights of sleep. You've had a poor quality of sleeping and breathing for years. And the parents have been struggling with so many different issues, and not the least of which is the ADD, ADHD discussion. Because the child who doesn't get a proper night's sleep with a good quality of breathing throughout the entire night is going to wake up and be unrested. And when you get a child who's had a poor quality night's sleep, poor breathing all night long, and you make that happen for years, you know what you've got? A 6, 7, or 8-year-old that's going to go to school and have trouble learning, have trouble sitting still, have trouble behaving, have trouble cooperating, basically have trouble fitting in to what is supposed to be a quiet and peaceful and learning environment. And it's not long after that where the phone call comes to the parent. And when the phone call comes to the parent from the school, what happens is, we have little Jimmy here and he's a little bit disruptive and we really want you to have him evaluated for ADD and ADHD. They're going to be diagnosed with ADD and ADHD. And our solutions are pharmaceutical. If we are given a pharmaceutical, it's usually in the form of some sort of a stimulant. And what that does to the child is it kind of pushes them over the edge and it brings them back to calm. So you basically take an excited or hyperactive child, you stimulate them more, and you bring them back to a so-called calm. But it doesn't make a better learning child. You're not going to have a child who's able to learn as well. So now you might have the child sitting still in class because they might be a little more numb or relaxed or calm, but it doesn't necessarily make them a better learner. If we have the so-called ADD, ADHD diagnosis, we're talking about hyperactivity. We're talking about all of the things about behavior and development that land in this category. And the interesting thing about research is, and there is current, ongoing, and past research that shows, children who are sleep deprived produce the same exact symptoms as kids who are diagnosed with ADD and ADHD. In fact, there's a nice study that showed children who were diagnosed with ADD and ADHD were mixed with children who were sleep deprived. And in that group of kids, when they tried to analyze them and look at their symptoms and diagnose them, they couldn't tell them apart. And if you have a group of kids and you can't tell apart who's an ADD child and who's a sleep deprived child, it's no surprise that maybe the ADD and ADHD has a cause. And maybe that cause has to do with the quality of the breathing and the sleeping overnight. And there's a lot of research out there, and one of the pioneers here is Dr. Stephen Sheldon out of Lurie Children's Hospital in Chicago. And he does a wonderful job of researching, and over the decades, he's come to a conclusion, and I've seen him speak, and it's not soon after he jumps on stage and he makes a statement that ADHD and ADD do not exist. They are an outcome of a sleep disorder breathing. They're an outcome of a poor quality of sleep. It's all about the quality of sleep. Another researcher who's produced beautiful research on the same topic is Dr. Karen Bonnick out of Einstein at Yeshiva University. Dr. Karen Bonnick has the largest study to date. 11,000 children were watched over 7 years. And they were divided into 2 groups, sleep disorder breathing children and children who do not have sleep disorder breathing issues. The children in the sleep disorder breathing group, over their 7 years, her study showed that they were 50% more likely to be diagnosed with an ADD or ADHD diagnosis and treated with medication. 50% is a coin toss for our child to be diagnosed and treated with a medication. Also in her group, they were doing testing. They were doing IQ or intelligence testing along those 7 years. And the children with the sleep disorder breathing, their intelligence testing, their IQ scores were dropping over those 7 years. And that's really not the way it works when you're growing and forming. The formative growing years for a child, when they're sleeping and breathing well, your IQ raises to a certain point and then you kind of plateau. We don't see IQs diminishing amongst children.
Interesting stuff, right? So this is just referencing back to what Dr. Moralia was speaking about with Dr. Karen Bonnick's research. Her research included 11,000 children, and those children were split up between disordered breathing, deprived children, and children that were diagnosed with ADD, ADHD. And in her findings, what she saw is that there was a strong and persistent association between sleep disordered breathing and a diminished IQ. And sleep disordered breathing increases the risk of ADD, ADHD by 50%. All right, so another one of those symptoms that we see present in children is bedwetting. And you might be wondering, oh man, gosh, how does this remotely relate to bedwetting? So again, I'm going to have Dr. Morelia speak more about that in the relationship.
Another thing that might happen is bedwetting. Bedwetting, it's a little more common than people are aware because it's also a best kept secret. Not many people are running around and advertising that their child is bedwetting at the age of 5, 6, 7, 10, 14 years old. But bedwetting does have a relationship to how we're breathing and our quality of sleep. And some of the causes for bedwetting relate to the way oxygen is exchanged in our body. And the way I'll describe it is this. If we're breathing through our mouth, that air coming into the lung isn't really filtered, warmed, or humidified appropriately, and the body can't exchange it appropriately. So a little less oxygen goes to the brain. Now, the brain is a very sensitive organ. When the brain recognizes little changes in oxygen, it goes to work immediately. Because once the brain starts to recognize a little less oxygen, it doesn't know if we're being choked to death, a very serious condition, or if there's an imbalance in how we're breathing at night, but it does start to trigger a little bit of the fight or flight response. And a little bit of the fight or flight response means the brain's going to look at the body and say, all right, if we've got a little bit of an oxygen issue going on, I'm going to pull oxygen from something that it picks to be unnecessary right now and maybe deliver it somewhere that might be more important, planning on a rare occurrence as if the oxygen was going to stop. So if the brain's recognizing a little less oxygen, all of a sudden it's pulled from the urinary tract. If the body pulls a little oxygenation from the urinary tract, it might void. So we might wet the bed.
So what can we possibly do? Clearly, it may not be what you think, right? So I'd like to introduce you to Connor Deegan. This is another video we're going to transition into here, a video of, very similar story, kind of like my son, but you're going to hear Connor Deegan's story through his mom. You do have to read this presentation. It's not spoken, so just keep that in mind, but I'd like to introduce you to Connor Deegan. love that video. It's always very touching to watch. So what do we do now? And what can a dentist do about all this? That might be the biggest lingering question in your mind. So we're going to talk about that, and we're going to transition and look at some cases, some children first that were treated in an oral appliance by a dentist. So I'd like to introduce you to Hunter. Hunter is age 10 in this before and after, and this is his before photo on the far left in comparison to his after photo. And you can already see some really great changes in his profile. We're getting that wide forward downward development here in the lower 2/3 of the face, right? So you can see the changes in the jaw. But also look at his bite here. You can see his before and after, and in that before, you'll notice that he has some impacted canines. So we're getting that expansion, right? And those canines drop down beautifully. And I'd like to point out that actually is, a mid-treatment photo of Hunter, not his final. And this is just after 10 months of treatment in an oral appliance. And really what the best thing about Hunter is after he started wearing the appliance, he stopped wetting the bed within the first week. And that's because we're getting him breathing and sleeping better. So this is Paige. This is Paige at age 11, and you can see her before and mid-treatment here. Wow, right? The changes in her profile are dramatic. You can see how severely underdeveloped the jaw is. It kind of melts into her neck, right? By getting that, expansion, that wide forward, downward. Look at the beautiful jawline here. And then of course, look at her bite, her before and mid here. You can't even see the bottom teeth, right? Her bite is so deep. And then fast forward, getting that expansion, and everything is just changing and progressing beautifully. So a remarkable transformation, yes. So you might remember Michael from the earlier images that we looked at. So looking at Michael straight on here, you can tell right away, yes, he's not overweight at all. Just when you're looking at his profile, because he is underdeveloped here, he has that retrognathic chin and gives the appearance of the double chin, making him look overweight, but he's not at all. So this is at age 9 and then age 14, his end of treatment photo. And this again is all with an oral appliance, right? This is all accomplished with just oral appliance therapy. Age 9 profile, age 14, look at that beautiful jawline. And here we go, here's his before and after bite. Just absolutely mind-blowing, beautiful. And this again is accomplished with wearing an oral appliance. But this is really what we strive for. This is just everything that we hope for with our treatment is, making our patients healthier, making them feel better, helping them live and feel a better life. And so this is that CT scan that we take in our practice. You'll see the before CT scan on the left, the after CT scan on the right. And I'd like to point out that airway. If you look in the before photo, that's a tiny, tiny coffee straw that Michael has been breathing through. And then fast forward to his final treatment photo, that beautiful wide black garden hose. We know he's breathing better. We know he's feeling better. But I'd like to point out also in these two images, look at the spine. I mentioned before that sometimes we'll see patients posture their head forward or tilt to the side. And that's, again, to compensate to breathe better. They're trying to open their own airway to get the oxygen they need, right? But think about the toll that takes on the body if you're doing that from early on in childhood up until 40, 50, 60 years old, right? You're going to develop a lot of chronic head, neck, back pain as a result of that, right? All right, so you might be thinking right now, man, if only I had known, and what about me, or what about my child, or what about my spouse, right? So we're going to transition here and talk a little bit about how we can, help you, your child, your spouse, or anybody that you love in your circle. But first, we're going to look at some adult cases. I mentioned that we're going to transition a little bit once we get towards the end of the presentation. Let's look at some adult cases that were also treated with an oral appliance by our dentist. And this is Dr. Tara Griffin. So you'll notice right away in her before and after photo here, the changes in her face, right? You can see in her before photo, she has a really, big smile, but it's a gummy smile, right? Also really tiny little eyes here. Looks like there's some symmetry issues in the face. And then when you look at her after photo, just beautiful. It looks more proportionate, right? So we're going to watch a little video of Dr. Griffin, and she's going to walk you through, how this treatment really transformed her life, but it also transformed her practice.
I'm Dr. Tara Griffin. We are here today in my clinic in Panama City Beach. I've been practicing dentistry for over 11 years. Before I discovered the Vivos appliance, I was suffering every day with chronic head and neck pain, TMJ pain. I was practicing dentistry and been practicing for 5 years, but I was already looking for an out. I knew that with this much pain, I could not continue to practice dentistry. I had chronic sinus and allergy problems, bronchitis. I was not sleeping throughout the night very well. I was waking up during the night. I had severe daytime fatigue where I would need to go home and actually take a nap in the afternoon, just at lunch, you know? And so I was looking for a solution to the problem, but I didn't know what the root cause was until I learned about the Vivos appliance. As soon as I started treatment with the Vivos appliance, within the first 2 nights, I was sleeping soundly throughout the night. My energy was better during the day. The pain that I was undergoing took a bit longer to get resolved, but within the first 3 to 4 weeks, my pain level was reduced by 2/3 or more. Within a month's period of time, I was breathing through my nose better. I wasn't having the same sinus symptoms that I was having before. And within 3 months of treatment, my asthma had improved so much, I had no more problems with the inhalers and the frequency I was having to use with all of my asthma inhalers. My overall health started to improve very quickly. I was my own first patient. However, as I continued to treat the next patient and the next patient going forward, I was curious to see if they were going to have the same outcome that I had, and they did. 9 out of 10 had the very similar outcome that I had. So they were sleeping better in just a few nights, actually getting their energy back. They were less irritable. The pain that they had was going away very quickly. The teeth were beginning to straighten and align over time. So even though with this type of problem, it can take some time to get the long-term results, the immediate symptoms start to improve very quickly. Comparing my before and after picture with the Vivos appliance, my smile was not symmetrical. My teeth were crowded. The gumminess of my smile was a major problem that I didn't like. I had unevenness in my eyes, also in my nose. My face was more round and less balanced, and that all helped to correct itself as well as I went through the treatment. When the Vivos appliance is worn in the early evening and while you sleep at night, it allows the jaw to relax. It allows the airway to open up. It allows you to breathe through your nose and to get the oxygen that you need to the rest of your body for your body to begin to heal. By breathing through our nose, we are actually getting much more oxygen to our brain as well as our lungs. And we're producing nitric oxide, which is a vasodilator to allow the blood flow and everything to circulate better. And so a big component with this is it forces you to actually breathe through your nose to get the oxygen where it needs to go into the body. So that's a very important part of this. If you're interested in learning more about the Vivos appliance, if this would be good for you, then I recommend you coming into a Vivos center to be evaluated to determine if this is something that could help you.
It's a great video. So this is a fantastic, excuse me, before and after photo or a CT scan. I mentioned again, CT scans are just our way of records in our practice, but this shows you a before and an after of a CT scan. And notice right away in these 2 images, the red and the before CT scan is not what we want to see, right? That's where the patient is constricted here. And then fast forward to the end of treatment, the blue and white, beautiful, big airway. But this gives some statistics behind the increase in the volume of the airway that we were able to accomplish. So in this before image, the airway volume started at 7.7 centimeters, and by 15 months of active treatment, we were able to increase the airway volume to 24.1 centimeters. That's amazing. Okay, so let's look at a couple cases and then we're going to wrap up here. So I talked a bit in the beginning of the presentation about some things that we look for in our patients when they come in our practice, right? Visible signs and symptoms, those identifiers that we can look at our patients and say, maybe something else is going on here. Let's dig a little deeper, right? So there's some things that stand out to me in this photo, right? How about you? Right away, I mean, a very long face, right? She's got these tiny little squinty eyes. The symmetry in her face is not proportionate. Double chin also, right? So let's fast forward and see what happens throughout her treatment. So that was after 1 month and then after 5 months. And here we are after 12 months of treatment. And this is just amazing to me, you know, her before and just a year into treatment changes. And really this is accomplished by getting the body to do what it was meant to do in the first place. We're guiding and growing the body to its natural growth potential. And in doing so for this patient, I mean, clearly it had, you know, fantastic cosmetic benefits. And this is all done with just an oral appliance. There was no cosmetic surgery here. You can definitely tell this patient probably was getting some confidence and, you know, dolled herself up a little bit. But again, this was just accomplished with oral appliance therapy. All right. And absolutely a remarkable clinical outcome here. Let's look at another one. So this is Christy. So Christy's chief complaint when she came into practice was she didn't like her gummy smile. That was her main thing that she wanted to change, is her gummy smile. Little did she know that going through an oral appliance was going to correct so many other things. And clearly you can see, you know, the before and after here and the changes as a result of her treatment. But yeah, she had that big smile, gummy smile. The symmetry you can see in her eyes is off, very oval face, right? So different facial structure. And then fast forward, look at her final, just more proportionate, really kind of looks like her younger sister, like she took 10 years off of her life. And then look at her profile photos, right? That's really curious to me. It's really interesting when you can see, you know, by drawing that line from the forehead to the chin, that how much growth we were able to accomplish on the jaw. But you can see in the first image here that the chin is behind that line. And what we want to see is the chin above the line. So if you take that line, draw it from the forehead down to the chin should be in front of it, not behind it. And so you can see based on these two images how we were able to get that expansion, that wide forward, downward. And then also take a look at the ears, right? So in the before photo, her ears are more pushed up and out. And then, of course, getting the body to do what it needed to do, the ears they fell back a little bit too, making everything more proportionate. And she had a lot of great things to say about us, right? So here's some things that she mentioned. When smiling, I noticed that I'm now physically unable to smile as big as I used to. My gums are now barely showing. My face feels different when I smile now. I don't know how to explain it, but it's a great thing. When I speak and eat, my jaw no longer pops. I can speak more clearly. Oops, I'm fast forwarding here. I can speak more clearly and feel a noticeable difference in the amount of room my tongue has. I can breathe very well through my nose now, and I'm very happy with the results. All right, so what is the goal here? What are we wanting to accomplish? Well, we absolutely want to get that great expansion in the dental arches, but we also need to promote healthy nasal breathing. That's extremely important, as you just heard from Dr. Tara Griffin. We need to discourage and eliminate mouth breathing, and we need to, you know, promote that nasal breathing, because nasal breathing prepares the air by filtering it, warming it, moisturizing it for optimal assimilation into the lungs. We also need to train the tongue. We talked a lot about that. The tongue needs to be up and forward in the roof of the mouth, and we need to strengthen and condition it. We also need to promote proper swallowing in speech, and we need to eliminate any bad habits. So thumb sucking, tongue thrust, reverse swallow. We're all going to work on some of those things to make sure we're moving forward in a successful path with our treatment. And so how are we going to do that? So in our practice, we do a series of screening, medical imaging, and diagnostics. So we have a CT scan. I mentioned that. We're going to definitely take a CT scan on you to see your airway. We're going to do a series of intraoral photos, extraoral photos, and exam on you to see if this treatment is really going to benefit you. And then we really do take a personalized treatment approach to our treatment. Every single appliance that we make is custom made for you. So when we do our records with you, the appliance that we make for you is going to be custom fit for you and only you. And what is it? It's a biomimetic oral appliance, right? So I talked a little bit about oral appliance therapy. Well, what is that? So we have an appliance for every age. We can treat children, as early as 2. We can treat adults, as old as, 80, 88, 89, you name it. We have an appliance for every age. We have a system for children. Typically our kids will be in an appliance until about 12 years old, or until their 12-year molars erupt. And then a lot of our our patients would either be in a DNA appliance at that point, or an mRNA appliance at that point. The DNA, it's going to, really get that expansion wide forward downward. But the mRNA is very similar to the DNA, but with the mRNA, it has a mandibular advancement component on the bottom, which props open the airway, so our patients are able to breathe better right away in the beginning of their treatment. So those are really the types of appliances that we have in our practice that we'll be seeing if one of those is going to be best suited for you. And we take an integrative therapy approach here, right? So we might need to incorporate another specialty doctor. Maybe we need to, seek the help of an ENT or a chiropractor or a myofunctional therapist, right? Those are all things we're going to evaluate when you come into your appointment. And of course, we have a lot of great technology in our practice. I mentioned the CT scan. We also have a home sleep test. So we might take a home sleep test on you because we want to see how you're sleeping and breathing. And that's all something that we'll evaluate when you come in for your first appointment. See if this is going to be a great treatment for you. And of course, if you have anybody else, your loved ones that you might be thinking that this might be a good treatment for them, then we would love to talk to them as well. I'm going to leave you with one last video, and then after that, we'll open up for any questions that you might have. And thank you so much for being here today, and welcome to the Breathing Wellness Movement.
I really feel like Vivos is one of the great answers to the healthcare crisis that's in America, because we're getting to the root cause of what ails a lot of us, and that is not breathing well and not sleeping well.
Trace back the journey of a sleep apnea patient. That patient is suffering for years before they ever get diagnosed. Once they are diagnosed, they're presented really with 2 fundamental options. You can go into CPAP and wear a contraption over your face every night for the rest of your life, or you can have what's called a mandibular advancement device, which will actually protrude your lower jaw in an unnatural position to hold your airway open while you sleep. And you can wear that for the rest of your life. Either of those 2 modalities are going to present that patient with a life sentence of having to wear this contraption, one or the other, every night for the rest of their life.
The interesting thing about CPAP and oral appliances is, although they're very effective treatments, if they're used over a lifetime, the person's condition actually gets worse over time.
Along comes Vivos and says, wait a minute, we have a better option that's all natural, non-invasive, non-pharmaceutical. We can say to a patient, you go into this oral appliance therapy with our protocols, and you go through this treatment for 12 to 24 months. And at the end of that time, there's a high probability that you will no longer have to wear an appliance or any kind of device.
Vivos is literally changing my patients' lives.
It has drastically changed my life. I don't have to use the CPAP anymore. Within just a couple weeks of using the appliance, I was able to breathe through both nostrils, something I couldn't do my entire life. This was revolutionary. Pretty much made me feel excited about life again.
She's sleeping better, I'm sleeping better.
You really feel like you've been given a new life.
It's amazing. I wake up and I'm not in pain.
Because she's sleeping better, is her attitude during the day is better.
I have a better quality of life now. I can't say enough good about it.
I'm getting instant benefit from it. I was amazed. I dreamed every night for 2 weeks straight, and I told my wife, I said, it's amazing. I feel sharp now. I don't feel drowsy all the time. It's been a long time since I felt this good. I wouldn't lay down and try to sleep right now without my Vivos device.
My asthma has gotten much, much better. Without the Vivos, I wouldn't be outside right now. There's no numerical value you can put on this kind of a change. I smile. And I haven't smiled for a long time.
Right after I started using it, I noticed the results really, especially with the snoring. My sleep apnea episodes are a fraction of what they were before. This product's phenomenal. It changed my life.
It's a very comfortable process, but I can see dramatic differences. Now I can really open my mouth. Before it would almost always click.
His ADHD is calming down, he's doing better in school. I can definitely see the difference and the change in him. It's a miracle.
I get to do things now that I would not have been able to. I would not hesitate to do it again.
I am 100% happy that I did this, and I'm thankful every day that I have it because I can breathe.
We bring hope to the millions of people and the millions of families, men, women, and children who suffer from this disease.
It promotes the body's own ability to heal itself because now the body can breathe and sleep well. That's exciting.